Okay, everybody, we're going to get started with our next session. I'm Dr. Sherry Whiteman, and I'm going to serve as the moderator of this session. In this panel, we'll explore the future delivery of healthcare from two highly respected healthcare leaders. Let's take a moment to introduce them to you. Dr. Catherine Satterwhite is the Executive Director for the Center for Population Health and Equity at Kansas City University. Prior to her role at KCU, Dr. Satterwhite worked for the U.S. Department of Health and Human Services as the Regional Health Administrator for Region 7, which includes Kansas, Iowa, Missouri, and Nebraska. She has also worked as an associate professor at the University of Kansas Medical Center and as an epidemiologist for the CDC. Dr. Satterwhite has an extensive experience facilitating collaboration between government agencies, health systems, academic institutions, and stakeholders across the public health and healthcare spectrum. Please help me welcome Dr. Catherine Satterwhite. Our other panelist is Dr. Rob McNab, a practicing internist in Joplin and Vice President of Medical Education for Freeman Health Systems. Dr. McNab is a 2002 graduate of Kansas City University of Medicine and Bioscience and holds fellowships from both the American College of Osteopathic Internists and the American College of Physicians. Dr. McNab is an associate professor at KCU and is board certified in internal medicine and lifestyle medicine. He boasts nearly 20 years' experience in hospital medicine treating acute health issues. Dr. McNab has long been an advocate for patient empowerment through education and has now established an innovative model of healthcare delivery to better service patients. Please welcome Dr. Rob McNab.
Good morning. So I want to thank MSSU and the Willcoxon family for hosting this awesome event. I'm thrilled that I got to be here yesterday and to hear our speaker this morning as well. Dr. Martin, thank you. So I want to start out, if I got my slides, please. Oh, wait, never mind. I got the power. I first want to start out by really thinking about what health means, and I think it's really good to level set with the World Health Organization's definition. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I think that's really important. We talk a lot about healthcare and treating disease, but I want to shift us back to the focus on well-being and really in all of those capacities, physical, mental, and social. And to really think about what the goal is. So when you think about health, what do you think about? So I've obviously kind of primed you by giving you this definition, but just take a minute and think about what health means to you personally and to the people that you love. So when you're thinking about that, is it just quantity of life? It's probably not. It's probably quality of life. It's probably thinking not just about time passing, but it passing well, finding joy, finding meaning, and really that place of well-being. So I also want to share just a little bit about KCU. You probably know KCU, but the reason that I'm talking about well-being is because that's part of who KCU is. We are community professionals committed to excellence in education, research, patient care, and community service while improving the well-being of the communities we serve. So a lot of what I'm going to be talking about today is anchored in that mission that we have at KCU. And we are really focused on a large part of the heartland of the Midwest, whatever you call this geographic area. So it's not just about our campuses in Kansas City and Joplin. It's about that whole community that we're really thinking about serving. I also want to start off by having a couple more definitions, and then I swear I'm going to get more into the meat of my presentation. So first of all, I'm going to be talking about the Center for Population Health and Equity. But population health is a term that we use a lot in medicine and healthcare, and a lot of us use it different ways. So you heard Dr. Martin this morning talking a lot about population health, a lot of what we think about from a healthcare systems perspective. So the population of people who are coming to us in healthcare. If I'm a pediatrician, it may be all the patients who I see in my clinic. From that sense, I'm really thinking about what are the health outcomes of a group of individuals, including the distribution of outcomes within the group. And that's a really important thing. That's where we get things like quality improvement projects. That's where we might think about how can I increase HPV vaccination uptake in my population of adolescents who are coming to my clinic. And we can think about specific things we can do. But I also want to think about community health, and that's really kind of where I want to think about where we can go together. And that's multi-sector, multidisciplinary engagement with communities in a culturally appropriate manner to optimize health and improve quality of life, to get to that place of well-being. So sometimes those are really a much broader geographic area. So we can drill down in different ways, but I'm going to use probably the term population health mostly, but recognize that that can be different when we're thinking about what our overall goal is. I also want to think about the terms equality and equity. So equality is where we give the same opportunities to an entire group of people. So in this case, I've given 4 bikes to 4 different peoples. Equity is where we recognize that those people are coming from different places or may have different needs. So I need to think about the goal, what I'm trying to get to. So in this case, if I'm like, hey, I just want everybody to be able to ride a bike because, hey, it's fun, or it might be a means of transportation. If I give everybody the same bike, not everybody can actually reach that same goal, that same outcome. Like, let's pretend that's my poor tall husband who is very tall and he's all hunched over. If I want everybody, my husband is way happier in the lower one because he's like, I have back problems anyway, and now I can sit up straight. So equity is really what we want to do. Recognize that people have different needs to get to the same outcome. All right, so getting back to this idea of improving well-being, what needs to change? We need to improve economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and importantly, to recognize the role of social and community context. And these are all sort of things that fit into this category of the social determinants of health, if you've ever heard that term, or the social drivers of health, which is probably something that we're kind of moving more towards that language, the social drivers of health. So we're thinking about how do those things fit into well-being? And importantly, what's modifiable? So when we think about what goes into a person's health, oftentimes we talk a lot about healthcare. You know, are they going to see the doctor? What's the doctor doing? Are they getting treated for maybe they're acute, like I'm sick, I don't feel well, I'm going to the ER. Or I don't feel well, I'm going to see my doctor, and am I treating whatever condition I'm presenting? So a lot of times we think of health as just that. What is the healthcare system engagement? But really, the majority of health are things outside of that system. So things like socioeconomic factors, the physical environment, and health behaviors. So there's a lot out there that we need to think about in terms of health that is not the healthcare system. Okay, so how do we do that? So how do we think about operationalizing these ideas of population health, community health, and equity? So that's sort of where this new center that KCU is creating comes in. We want to build momentum around understanding and addressing those social factors that impact health within and outside of the traditional healthcare setting, bold letters, in partnership with community and local organizations to better prepare students to practice osteopathic medicine, clinical psychology, and dentistry, and importantly, improve the well-being of the communities we serve. Okay, so there's a bunch of sort of goals that I've identified. I'm kind of new. This is a new thing for KCU, but it's super exciting. So I want to think about how are we developing future leaders who will champion equity and serve as population health strategists and advocates within and beyond the healthcare setting. How are we going to engage with the community to improve well-being? How are we going to identify and address timely healthcare and public health issues? And how are we going to transform communities through policy and systems change? And we're working across 4 different pillars to do this. We're thinking about the academic perspective. We're thinking about how does research fit into this? How does service, both clinical and non-clinical service? And how is community engagement a sort of key foundation to all of this work that the Center for Population Health and Equity is being positioned to achieve? All right, so now I want to give you a couple examples. So this is just life expectancy in Kansas City, Missouri from 2015 to 2019. And you'll see here that life expectancy is lower with that deeper blue color. So a life expectancy of below 70. And as much as we talk about quality of life, I am going to share that I'm going to use life expectancy, this example, because it is one of the most objective quantitative data assessments that we have. All right, so there were 6 factors that were identified as being highly correlated with life expectancy in these Kansas City census tracts. These are the 6. All right, I'm going to just think about it for a minute. So we've got asthma, diabetes, exercise, sleep, smoking, and stroke. They're just up there in alphabetical order. Which one of these do you think was the most highly correlated? So I'm going to count to like 5, give you some time to think, and then I want you to say it. It could be like a whisper if you're not like into shouting out things. That's okay. But just like, I want you to say which of these was the highest, do you think was the most highly correlated? Okay, ready? 1, 2, 3, 4, 5.
Sleep.
Oh, somebody yelled sleep. But there were a few things, but I did hear sleep, and it is sleep. So what we saw, so again, if you look at this figure on the left, that darker color is lower life expectancy. The figure on the right, the darker color, represents a higher proportion of the population receiving fewer than 7 hours of sleep per night. So what we see is if you're not getting a lot of sleep, you're also maybe living in a place where you have a lower life expectancy. So less sleep, lower life expectancy are correlated. All right, so let's think a little bit about sleep. Okay, so why might people not be getting enough sleep? So think about this for a minute. Probably a lot of reasons, right? But we need to think from a population health level. And when we think about that, we need to think at different levels of intervention. So we can think the individual level, because instinctively we're like, well, just go to bed earlier. And you can tell that to people, but the reality is there might be outside factors that are preventing them from going to bed earlier, or requiring them to get up earlier. So we might say, get off that phone. Keep your phone outside of your room, which we hear that all the time. I'm not gonna lie, I use my phone as an alarm clock, so it is definitely on my nightstand. So let's think, we gotta meet people where they are. Go to bed earlier. Maybe you should be creating a better routine, which is great and true. All of these things are true. From a medical perspective, we might want to assess sleep apnea. In Kansas City, high schools start at 7:20 a.m. So this is just an example of, maybe a system level thing is we need to think about maybe starting school a little bit later. If any of you guys have teenagers, 7:20, that is early. My kids want to get up at like 10:30, which is obviously not when we're going to start school, but that's an opportunity that our students and our parents may be able to get a little bit of extra sleep if we sort of intervene at a systems level. At a policy level, one of the challenges in the Kansas City school start times is we can't get enough bus drivers. What if we pay our bus drivers better so we can get kids to school when they need to get to school instead of having to rely on 2 shifts of bus drivers because we can't get enough? What if we increase the minimum wage so that people don't have to work 2 jobs and therefore might be able to sleep better? What if we reduce daily living costs? These are big ideas, but they are all things that you can see might impact people's ability to get a good night's sleep. All right, so what could we do from KCU's perspective? We can certainly figure out how we are addressing sleep in our curriculum so that we're not just thinking about sleep as an individual function. We can talk about it in the context of other social drivers of health. So that's our academic pillar. We can partner with community health centers to understand the prevalence of sleep deprivation and the drivers. So we can understand then how to develop an engagement plan. And then importantly, we don't want to do this alone. We need to understand if there are other community partners in this space. And by the way, the school time change, not a new problem. People have been trying to address that for years. But we don't want to do that on our own. We want to figure out how we can partner with people to do it. Okay, so let's use a different example. So what you're seeing here are county health rankings from 2024, hot off the press, from the Joplin geographic area. So the yellower color represents the less healthy counties when we're thinking about how it compares to counties across the United States. So that very dark green is represents the healthiest counties in the country. So you'll see here in this area two things. One, we have some of that lighter green and some of that yellow, but we also have a variety. So there are a lot of different things going on in this part of the country. Oh, sorry, I wanted to say the factors that go into these rankings, it's a whole bunch of factors, including things like length of life, but also quality of life. Thinking about how many days do people report having poor physical health? What does our low birth weight situation look like? And there's a whole bunch of factors that we also think about when we think about place and health. Social determinants of health, of course, internet access. That is a very important factor when we think about quality of life and how place impacts our health. Housing types and availability. Health vulnerability, thinking about chronic conditions that people already have, and how are those factoring into the ability to improve well-being. We also think about other things that are very clearly place-based, like hazardous sites, lead mining, the availability of parks, how walkable are places, and I think this one's gonna hit one, transportation infrastructure, and that's a big challenge here. Okay, so I wanna show you one other sort of assessment of health. So this is something called the Environmental Justice Index. It measures the cumulative impacts of environmental burden through the lens of human health and health equity. And what we get is a single score to help identify areas most at risk for health impacts of environmental burden. And the reason I'm showing you this is because, again, we're looking at variety of communities here. So there we have low all the way to high in this geographic area. And I'm highlighting this because we tend to lump things really big. And I think we don't pay attention in rural areas in particular with the variations within rural communities. Not everything is the same. So this is just an example of different things that can impact how a community's health is. Again, lack of walkability, lack of health insurance, lack of internet access, high prevalence of mental health concerns. This is why, when I'm thinking about how we are operationalizing population health and equity at Kansas City University, it is incredibly important that we connect with stakeholders. There is no space to do this if you're not collaborating with other people. One of my goals in this center is to not create new programs, but to figure out how we can help other community partners expand, enhance the things that they're already doing to create a greater impact. And those partners are broad ranging. It's partners like MSSU, it's partners like Freeman and Mercy, philanthropy, state government, our huge KCU alumni network, faith-based organizations. There is a role for everyone in this work. And I do want to finish just for a minute talking about academics. So KCU is an academic institution. We have 4 degree programs and over 2,000 students in those degree programs. So here in Joplin, we have osteopathic medicine and dental medicine. In Kansas City, we have osteopathic medicine, clinical psychology, and biomedical sciences. So what we're really thinking about is how to put this mindset as an active role across the curriculum that we have at KCU. So I just want to give you an example. We are creating a new evidence-based medicine and population health course for our osteopathic medicine students. It includes things like critical literature appraisal, the reality is medicine changes, and population health and public health and how those integrate with clinical medicine changes. So we need to provide our students with the skills to be lifelong learners. We're also thinking about the social drivers of health and putting those in different places in our curriculum. Health systems, informatics and AI is going to be a part of our curriculum as well. Importantly, again, it's not just about this AI, it's about how to think about AI when we think about providing clinical care. How do we evaluate whether it's a good thing? Is it a good thing? Sometimes it's actually, yeah, it is a good thing, but you're charged more if you want to use that. Like your health insurance is going to get billed more, and it may not be covered. So it's thinking about all of those pieces. And we're really trying to focus on coordination across our degree program so that all of our students are aware of this and that they're working together. And hopefully they're going to be working together in some of these programs that we're going to stand up. So first of all, Score 1 for Health, it's not new. It's been around for 30 years. And it's a program where KCU goes to elementary schools and we provide some health screenings. We do physicals, we do vision screening, and we do oral health screening. So we've had that program for a long time. We're gonna figure out how we can maybe even make it better. How can we make sure we're really creating a robust follow-up and engagement program? The Student Health Advocates Program, those consist of student teams, 2 to 3 students from different programs who are going to create a longitudinal relationship with families, with individuals who are already working with community partners. So we're gonna hopefully again be able to expand their services and provide more touch points on the issues that are important to that family or individual, or places where they see needing help. It could be, I need you to help me figure out how to engage with my insurance company. I was billed, I don't think I should have been. I need help finding a primary care provider. It may be that we're checking in with them. Hey, are you doing okay taking your prescription? Do you need a pill organizer? Things like that. We're also going to be creating a program that I've temporarily called Academic Confidence Through Expanded Services. That's really focused on the mental health needs of kids. We know, and we're gonna start by thinking about how we can partner with school districts to provide accommodations testing. So we know we have some young kiddos who maybe are struggling to learn and maybe need some different accommodations, but accessing that evaluation, that psychological learning evaluation, is a huge barrier. There's a long wait list, it can be very expensive. So what we're gonna do is try to expand the capacity of schools to provide that, and then hopefully get those kids the accommodations they need. And we have a lot of plans for expansion of that program. And then I'm also gonna create a research lab. So this is really gonna be focused on population health, public health research, and we are using research in the broadest sense of the word, so scholarly activities. We know there's a lot of needs sometimes to figure out how, if we have materials that are culturally appropriate, that are tailored to the population we need. I'm also very interested in figuring out how we can give tools to our health leaders, to our policymakers, to help them make informed decisions about whatever is important to that community or that system. And then this research lab is really also going to be focused on the whole person. Much like what Dr. Martin mentioned, we will do a little bit of biomedical research, or basic science research, but we're really focused on that whole person and how are we intervening to improve the well-being of individuals and communities. I'm almost finished. I also want to say that we're going to have space for this. Through the generosity of Congress, under the leadership of Senator Blunt, we are going to be building a new building on Joplin's campus where we will house the staff and some of these programs. We do anticipate starting to build relatively soon, and we'll be renovating a building on our Kansas City campus as well. And I really just want to emphasize, so first of all, thank you, but that we're really focused on addressing upstream causes so that we can set people up for long-term success. And it's really important for us to be in partnership with you. So if you ever have any ideas, you can always let me know. That's it. Thanks. And I'll turn it over to Dr. McNab now.
Thank you, ma'am. I feel like our lectures are like peanut butter and jelly. Am I live? Oh, I didn't hear myself. Are we good? All right. Well, thank you for having me out this morning, guys. I love being on campus. You may not know this, but my wife and my son are alumni of MSSU, so it's always near and dear to my heart to be able to come out and spend time with you. So if we're going to talk about the future delivery of healthcare, I think what we should probably start by defining where are we now and what are our challenges, and hopefully that'll help guide in what makes sense. So one thing that's really important to know is that we are seeing this incredible expansion in senior citizens in our country. Starting in 1950, we had about 8% of the population were over the age of 65, but now we're somewhere close to almost 17, going on 20%, and by 2050, it will be around 22%. So we're getting close to about 1 in 5 Americans are now in their 60s. And as we see that trend, at the same time, what we see is that Americans are starting to experiencing a fall off in lifespan. You know, for most of my lifespan, we have always, every year, expanded out. We've gotten to live longer and longer. But starting in the 2015s, that really fell out quite a bit. And the general consensus on why that might be is that we've invested very, very heavily in high-tech sick care. If you have septic shock, oh my goodness, we've got great medicines. If you need surgeries, oh my goodness, we have the best surgeons in the world. But where we really have perhaps fallen short is in healthcare. How do we keep our populations healthy? And so if you look at the Commonwealth Fund, what you can see from 1980 to 2015, that very bottom line there is the United States falling out from the rest of the industrialized world in life expectancy. And that's despite the other slide that's showing that from 1980, when we were spending about 8% of GDP per year, we're now at somewhere closer to 17 to 18% of GDP. And that's about $4.1 trillion per year that we're throwing at this problem, and we're not seeing the results that we want. And perhaps this is why. Today, 6 in 10, 60% of adult Americans have at least one chronic disease, 4 in 10 have at least 2 chronic diseases, and somewhere around 1 in 10 have at least 6 chronic diseases. And keep in mind that only somewhere around 20% of the population is over the age of 65. So a lot of these people with chronic diseases are clearly much younger than the age of 65. And why is that? Well, it turns out that when you look at, well, what are the chronic diseases that we're suffering from, these are pretty consistent with some of the other speakers that we've seen today. And all of these things have something in common. By and large, they're very heavily driven by lifestyle changes, by lifestyle habits that we have that either encourage or discourage disease process. I think I went the wrong way on that one. Oh, no. So in 2004, 20 years ago, the American College of Lifestyle Medicine was created. It is a consortium of primary care physicians, nurses, healthcare workers, respiratory therapists, physical therapists, who all have one mission. We know that unhealthy lifestyles are what's fueling chronic disease in our country, and we need to do something about that. And these are the 6 pillars of lifestyle medicine that we feel like when you address these things, they prop up and build the health of our communities. Proper nutrition, physical activity, stress management, avoiding risky substances, restorative sleep, we just heard about that, and social connections. We are very social animals, and when we neglect that or when we try to replace that with social media, it does not work very well. So, a lot of people will tell you that slide's interesting. A lot of people will tell you that aging is just a part of the, oh my goodness. Somehow my slides got really derailed here, but we're gonna struggle through. So a lot of people will tell you that aging is the issue, that as we get older we get more frail, and that's just the price that we pay for living longer. But I want to challenge that. What was supposed to be there was a picture of a 105-year-old man on a bicycle named Robert Marchand. Well, he's not up there, so we're just going to have to hallucinate him. The picture was him in his racing suit on his bicycle. He was 105 at the time, and he's competing in world events for his time trials on a 10-speed, which I could not do in my 50s. And he retired at 106 and then passed away at the age of 107. So if birthdays are just super toxic, I don't understand how a guy at 105 can competitively ride a bicycle. Something does not quite jive. And so when we look at where we are now to where we want to be, I think that this slide to your right here is something that I want to talk about. So medicine 2.0 is the standard of care right now. Medicines, surgeries, healthcare as we see it, that is reactive and not proactive, will do this for us. It'll slow down the dying process, and more importantly than that, at the very bottom there you see that little hump. I call that the marginal decade. So in 1950 is when nursing homes were invented in this country. So 70 years ago-ish. Didn't have them before then. But today we have 2.6 million Americans permanently housed in nursing homes. So in a mere 70 years, we have really been able to keep people alive longer, but at very low levels of health. And so as you can see, I can keep you alive for the last 10 years of your life, but your health span is not where we want it to be. You're not able to live the quality of life that you want to, but you are still alive. But what we need going into the future is what we call medicine 3.0, where we can keep your health span high throughout your entire lifespan and then have you drop out very abruptly in your last days. So we want to keep you at home and healthy and happy until it's time for you to meet your maker. All right. Now, aging with function is what drives health span, and that's influenced by a lot of things: genetics, lifestyle, access to health care, environmental factors. And I think that a lot of us think that genes are destiny, but I would argue genes have a role. Genes really kind of load the gun. In a lot of ways, lifestyle choices are what actually pull the trigger on that. And so let's look at that. So to prove my point, I'm not really sure how the pointer works on this deal. I don't see it. This is one of my favorite slides. This is from the American Heart Association 2019. And what it's looking at, your risk of having a vascular event, myocardial infarction, heart attack. This bottom line is measuring number of ideal health behaviors. Did you get that 7 hours of sleep? Do you have good nutrition? Do you not smoke? That sort of thing. And on this far side, they're measuring number of ideal health factors. Do you have high blood pressure? Do you have high cholesterol? Do you have diabetes? And I think it makes intuitive sense to us that if we have all of the ideal health factors, we were just born genetically gifted, and we just don't have a lot of health problems, and we have all of the best health behaviors, then our risk is very low. That makes sense. Nope. No pointer. But it also makes sense that if you have all of the bad health habits and you have none of the good health, then you're going to have the highest risk. But what I'd like to help you see is if you're like me and you got type 1 diabetes and you do not have good genes and you got some cholesterol, then, I don't have all the good health factors. So my risk may be over here, but because I have all of the best health behaviors, because I do them to save my own life, that's my risk right there. Well, what if I was genetically gifted? I'm just born into a completely healthy family. My genetic screen's completely normal. I have zero risk for excess health problems. But I have all of the bad habits. I smoke, I drink, I sleep poorly, I don't exercise, I take no care of myself. Well, that's my risk. And so the whole point of this slide is most of us are not born genetically gifted, but we all have the ability to control our lifestyle choices, and that actually puts you in a better risk category than the person who did win the genetic lottery and has it all to lose, which I think is very powerful. Wow. Oh my goodness. There he is. Hey, it's a 105-year-old. See, maybe I didn't hallucinate him. Yeah, there he is riding his bike. All right. Oh, technology. I love it. So this is a very interesting study looking at 10,000 Australian women who were in the ages of their late 60s. And what they did was nothing. They looked at these people's health habits. They categorized them into three populations, looking at were they socially active and had good health habits, were they socially active but didn't have good health habits, or were they inactive and social? And then they followed them for 17 years. And what they found was, oh my goodness, that the people that had the lowest amount of social connectivity and were inactive had the very highest risk of developing dementia, even more than the people that were active smokers. So being socially connected helped preserve our brain more than did you smoke or not. Of course, the people that were the most socially connected and had the best health habits also had the least risk of dementia. So, oh goodness. So this is something that I pulled from Medscape, which is a medical journal for internal medicine doctors, looking at a conversation about geriatric testing of VO2 max. So VO2 max is a way to measure the amount of cardiopulmonary reserve. So when I'm talking with patients, I describe it as, what's the size of your engine? You know, when you're 20, you probably had a V8, but somehow by the time you're 60, maybe you're a 4-cylinder, or maybe you're a lawnmower engine or something like that. And so, are you a Lamborghini? Are you a Geo Metro? And why that's important to know is that when you measure people's VO2 max, and we're looking at this slide over here on the left-hand side, we're breaking that into quintiles of VO2 max, and we're measuring survivability. And what you can see is the people with the very lowest VO2 max compared to people with the very highest VO2 max have a 5-fold increase of dying from any cause. And just think about that for a second. If you get a fever, your heart rate goes up. If you develop sepsis, your heart rate goes up. If you break a bunch of bones, your heart rate goes up, because you need to stabilize that ailing system and be able to get it to survive while it's repairing. We need cardiopulmonary reserve to do that for us in an emergency. For example, as we sit here today, you guys are using this much of your lung capacity to breathe. But if we got up and ran around campus, you would discover you've got a lot more lung capacity that you can tap into to do the hard work. Your heart has that too, and we call that VO2 max. So this is a patient that I saw in the clinic who has a VO2 max of 26. It's a 66-year-old gentleman who has very low. He's in that 5th quintile. And so he had suffered a really significant illness and was trying to get his health back. He did not know how low his VO2 max had gotten and what a tremendous risk factor that was for him. And so a lot of people would say, well, you know, 20-year-olds have better hearts, 70-year-olds have weaker hearts. That's the way that it goes. But there's at least 10 studies that I can point to that show that when you take 70-year-olds and you put them into training with 20-year-olds, the 20-year-old population and the 70-year-old population regain VO2 max about the same. So the heart is just a muscle. At any point that you start to exercise that muscle, the performance of that muscle can go up. And so age is not a determinant necessarily on what your ultimate VO2 max is. It's what you do with it. And so when you look at, oh my goodness, those are so goofed up. So the other benefit of VO2 max is that it influences our risk of dementia. And anybody that knows me knows that there's only 2 diseases that I'm terrified of, and it's a stroke and it's dementia, because those things don't necessarily kill you, but boy, they really can do a number on the quality of your life. Also, not particularly curable. So we want to make sure that we avoid these things. So studies looking at exercise and VO2 max turns out that there's a very interesting correlation between that and dementia risks. So this is what an atrophied Alzheimer's brain looks like compared to a normal looking brain. And what you see is that people that have higher VO2 maxes have the much bigger brain volumes. They have far less atrophy, and they have thus far more cognitive function. And this is a study from Finland. It's called the Finger Study, the Finnish geriatric study. And what they did was they took 1,200 people who were at high risk for dementia between the ages of 60s and 70s. 600 of those people were just given some general advice. 600 of those geriatric patients were given very detailed nutritional recommendations and exercise plans, social connections, and medical assistance, and making sure that their metabolic systems were doing what they needed to do. And what they found was that there was a 40% decrease in the rate of dementia. But more excitingly than that, in the treatment arm, they actually saw a 29% improvement in overall cognitive function. So from the time that those people started the study to 2 years later, those people had better recall, faster cognitive function, better executive function. So even though they weren't, you know, where they were maybe compared to another cohort, they were actually able to see improvements in their 70s. And I think that's pretty exciting as somebody who's maybe way closer to 70 than some of the people in the population that we got here. So this is actually the slides looking at overall VO2 max, and the top slide is brain volumes. So the higher your VO2 max is over that period of time, you retain more brain volume. This is cognitive function, the bigger slide. Over time, you keep that heart healthy, your brain power stays better. All right, oh boy. So this is probably the last slide that I think is probably my second favorite slide. This was a study looking at patients in their 60s and 70s that they decided to see, could we improve strength in elderly populations? So they took a cohort and divided it into two, and the first group was the control group. They gave them some basic recommendations and basically told them live their life. The other cohort, they took to the gym for 1 year. They got them a personal trainer, worked on their nutrition. And as you can see, no surprise, 70-year-olds gained strength just fine. So you can see that top line, strength is going up, whereas you can see over that year with the control group, nothing really happened. And then a funny thing happens in this study. At the end of 1 year, they pull the plug. They get rid of the trainer, they cancel the gym memberships, and they say, that's it, folks, go home. And then they sat back for 7 years, and they just followed both groups. Now, if you were in the control group, who basically didn't change their lifestyle at all, not only did they not get stronger, but their strength fell over those 7 years. And if you were in the control group, your strength got considerably better during that year. And then if you stopped exercising, your strength began to fall. That makes sense too. But look what an investment of 1 year worth of exercise did for the intervention group. Over 7 years, they were always stronger than the control group. So a 1 year investment in just lifestyle changes and activity netted these people almost a decade's worth of benefit. They were far stronger and far more resilient than they were destined to be. So even if you say, well, I'm going to exercise, but I don't think I can do that forever. It's just not me. A 1 year investment got these people a 7 year return that I think is invaluable in terms of functionality. So with that being said, I think that this lifestyle interventions are really where we need to be focusing our efforts, and how can we help people rebuild health. And when I'm talking with my patients, whether they're 19 or 79, what I'm telling them is this: if you're drawing breath, we can improve that functionality and we can improve that health span. So I apologize for the bad slides. I was talking bad about Max back in the back, and I think that the Apple people got a hold of me, but I hope the information was provocative to you. So thank you very much. Thank you.
Okay, so now it's panel time. What questions do you have for Dr. Satterwhite or Dr. McNab?
My question is for Dr. McNab. Obviously, there are benefits to exercise, especially for everybody, but in the geriatric community. If we have so much information, why are insurance companies not on board for like long-term health wellness programs, such as therapy or outpatient like physical programs? Because we have a lot of in and out as far as like short-term rehab. They get to stay like 3 weeks and then they go home, and it's just a cycle. So how do we get insurance companies on board to pay for that?
I love that question. So in my opinion, and it's just my opinion, I think that how you format the conversation has kind of controlled how people react to it. And so our model has been identify a disease, identify what is the treatment options, and then convince somebody to pay for it. That's kind of how we do business. But is sarcopenia, or loss of muscle strength, is that a disease? Is insomnia a disease? Is, not having quite the range of motion as a 30-year-old, is that a disease? They're not. They're substrate that drive disease process, right? And because we're focused on pathological care, ask me how to treat a stroke. That I'm really good at, and insurance companies know they have to play their role. How do I prevent a stroke? How do I invest in avoiding chronic diseases? Well, that's not the model, that's not the paradigm that we're working in. And so you've identified the problem. We have got to make an infrastructure commitment, i.e. population health, to say, wow, we've got a lot of older people now, and we're collecting all this chronic disease. If we invest in the things that are not diseases, but they're the substrate that build disease, well, in the long run, we get a healthier population.
So, and I'm going to add to that a little bit because I think it is a really good question. I think the reality too, so we want to do things because they're the right thing to do, and hopefully everyone feels that way. But the other reality is there has to be an economic argument. That's how insurance works. So if we can move to that 3.0 model that Dr. McNab was talking about, where our quality of life is a lot better for a longer period of time, then probably we will have fewer healthcare costs at the end of life. And for those of you who might not know this, the majority of our healthcare costs are at the end of life. My husband is an ICU physician, so I feel very familiar with this, even though I'm not an ICU physician. So I think that there's a case to be made that we have to justify it from a financial perspective too. And I think there are people trying to do that. So it's the right thing to do, and what's the financial argument?
So to just keep in that vein of thought, the question is, because of the financial perspectives that have to be considered, investing is what's needed now, and we know that return on investment won't occur for another 7 to 10 years, so how do you keep that conversation going with those investors to prove that they're going to get their ROI in that 7 to 10 year period?
Yeah, also a great question. So my background is public health. So this is something that we struggle with a lot. Again, when we do our jobs well in public health, nobody sees it, right? So it's hard to sell, and that's why historically our funding for public health has gone like this. That's why all of a sudden when COVID hit, we were at a down cycle. So now we're at an up cycle, and there's infrastructure investment, which is a little bit not what you asked. But there has been a lot of good research on these longer term impacts if we invest in, and I think that 7-year study is a great example. Even though it was a 1-year investment, there was a sustained difference in people who got that investment. So I think we have to tell a lot of stories. And we have to be able to tie those anecdotal stories back to the evidence. So, I think stories resonate with people. There's a reason why I told the sleep story and why Dr. McNab shared patient stories. So I think framing matters a lot. I don't know what your thoughts are.
Well, we have got to find a way to try to stabilize the situation where we can continue to take good care of the people that are currently have health issues that they have. That's costing us $4.1 trillion per year. And we throw about an extra $1 trillion per decade at this. We just every year, every decade it costs us an extra $1 trillion. But at the same time, we have to spend that extra money because we need ICU doctors, because we've allowed people to get so sick. So simultaneously, we have to fly the plane and find a better way to design the plane to serve its purpose. So how can we divide up our resources to say we have to start the best investment in our health while still giving due diligence to the people who their health is already compromised. And I think that's a difficult use of resources.
And I think it's also where we think about policy level changes, and those can happen at a health systems level, they can happen within a clinic, but they can also happen in city council. So again, I'm going back to my sleep example. One of the ideas is there's something called a predictive scheduling ordinance. So that means that employers need to give employees more than 24 hours notice if they're going to need them to pick up an extra shift. And you can imagine how that might impact your sleep. So there's lots of things that from a policy level that have a huge ripple impact that maybe aren't even so hard. So that might be a good space to make sure that we're thinking about too.
Thank you. Do we have any other questions?
Dr. Satterwhite, I'm interested in what you said about sleep because my wife likes to sleep, and I just texted her and said she's going to live to be 120, so good news for her. In all seriousness, you've mentioned your government engagement, your public policy with what you're doing now. There's some people that argue that the government is too involved in our healthcare, and some that would argue that the government needs to be more involved, and you've given some great examples, both of you. Is there a happy medium? Is there a way we can be more engaging with the public about their health in a way that they have more ownership in it themselves?
So one of the things that I'm really excited about, so I started 4 months ago. I'm from a small town in Kansas, and I had only been to Joplin a little bit before this job, and I've since been actually really excited to have been here multiple times and learn more about the community. And one of the exciting things in Joplin is it feels like there's a lot of momentum about workforce wellness. And so the reason I'm highlighting that is twofold. It's a space to invest in individuals' health, but it's also that economic argument or that economic case that you can make with employers, right? You keep your people healthier, it's gonna be better for your business. And there's a huge ripple effect. So that's a space where you can encourage your employees around their own health, but prioritize it from a workplace. So it's investing at two different levels, but for overall community good. So I think to your point about government, the thing that I would say about that is government is local. Like that is the most important. You know, I worked at the federal government. It's one of the reasons why I wanted to pursue this opportunity with KCU, because the federal government's awesome. There are also a lot of barriers sometimes. Our big changes and big opportunities are with our city councils, our county boards, and our state government. So that's sort of a really great space for people to advocate for those policies, and I also mentioned this importance of, I want to be able to create sort of one-pagers, like actually one page. If you guys ever heard that one pager and then you get 3 pages, you're like, really, not one page. So like really clear things that we can use for the public, for community organizations, for policymakers that sort of highlight these things. So, and I think there's a lot of opportunities in lifestyle and health behaviors too. People are always wanting to know what's like one thing that I could do, that I could achieve that would have an impact. You know, because I think we get thrown a lot of information, you know, don't smoke, don't drink, exercise, eat well, sleep more. So that seems like a lot sometimes. So it's also, I think there's an approach where we can, again, meet people where they're at. What's one thing that you can do that you feel like you can achieve and sustain? So I don't know if that helps or not, but.
You know, just to speak to that for a second, you know, I think a lot of times the conversation is where does the onus of this conversation fall? Is it the individual's responsibility to master their health? Is this a societal issue? And really, all these players are all equally important. You know, if you believe the World Health Organization, currently 1 out of every 2 human beings on the planet Earth is now overweight. This is not an individual problem. This is an emergent property of systems that we are all being impacted by. When one person has a problem, maybe that's their problem. When 50% of 8 billion people on the planet have the same problem, that's a system issue, right? And you know, human beings are like every other living organism. We always kind of fall to the path of least resistance, right? We do the easiest things. And so when we're designing systems, you know, when our city engineers are designing this town, if it's inconvenient for me to ride my bicycle to work, I'm not going to do it, you know? So the things like that, you know, that encourage us to have this health be a feature that we are building into our systems, that's really what we need, because that's what human beings are going to actually do. And so it's all of those things.
And it's also when we think about training and education and how we are preparing our clinical providers to address people's overall health, it's also about not blaming the individual. And I think we are still in that space too, where we probably overemphasize individual choices and actions. And it's much more complicated than that. So we need to be providing that kind of training and space for our clinicians who are that front line to help approach health differently and more broadly, and with a recognition that it isn't just the individual.
So currently, we are participating with the corporate challenge here for the school districts in Joplin, and it's super fun. So I have these people come into the office, and they're weighing in, and they're doing in-body scans and that sort of thing. And you can just look in their eyes, and you can see the fear of being judged by a stranger when they're getting close to that scale. They're not happy with where they are, and they're really worried about what you're about to tell them. And and as a healthcare provider, I just want to help you with your healthcare problems. I don't need you to be worried about my judgment. I want to help you with that. But boy, the psychology of these issues are really impactful on will you seek care and will you allow people to help you and how will you interact with that. And I have really found that wellness coaching and being able to partner with people to work with them to be able to get past the psychology of those things that they're working on is probably one of the more important aspects of will they be successful or not. If what's going on inside your head will not allow you to make the progress that you need to, boy, it's just going to be really difficult to get your health to go in the direction that you want it to.
Can any of you speak to the role of faith-based organizations in partnerships for healthcare system in our area?
So just to speak more to the faith-based organization, yes. So when we're thinking about partnerships in improving well-being and addressing community health, the big thing is I think we need to make sure that we are thinking about everybody. Faith-based communities have a huge role to play, and it is really critical. The faith-based organizations, people are engaged. It's a place where people come and are part of a community. And I think that there are all the opportunities across that huge stakeholders list. Every one of those can play a role in a lot of different ways. And one of those things is to listen. That's a huge role that we have in healthcare and the health system and population health, is listening. What would be useful? What's important? One of the favorite things that I've gotten to do, I've met with a lot of people in both the Joplin community and surrounding areas, as well as in Kansas City, is I tell them about this new center, and I say, hey, based on what I've told you and what you know, what's like your dream? What would you say? Hey, Catherine, it'd be super awesome if you could work on this. So my job is to listen and try to figure out what we can work on together. And I think faith-based communities are a huge critical role to a lot of populations in our communities.
Sure. So, the Seventh-day Adventists in this community and other communities, the pursuit of health and healthy habits is just kind of baked into their religious ideology. And so when you look at studies looking at that particular group, they live the longest, they have the least amount of heart disease, they have the least amount of dementia. And where I really think that that's the best opportunity, I don't think the most important word in the faith-based community is the community. Health is a sport that you should not practice by yourself. When you have the support of your loved ones and like-minded community members, then that is going to make you more resilient on your health journey. And so any community that you resonate with that can help support you in that or any of this is going to be a tremendous boon.
Do we have any other questions?
Yeah, so I was wondering if you might talk about how population health and lifestyle medicine might cut across medical disciplines that maybe don't seem at first to lend itself to lifestyle medicine or population health. I'm thinking about ICU physicians and nurses. I'm thinking about the emergency room. So can you speak a little bit about how an individual provider might bring some of those lenses into that work that is dealing with more of that immediate sickness and disease care?
boy, she's like she's planted in the audience. So, yeah, I love that question. So, right now, KCU is starting up a lifestyle curriculum track for the medical students to be able to add in these facets of their education to see how do lifestyle impact the drivers of chronic disease and what tools are effective at actually helping people out with that. Whether that's wellness coaching to get people from a pre-contemplative stage of interacting with a problem into, an active role with that, or how there is synergy with these things. Like for example, 40% of adults suffer from chronically poor sleep and insomnia, which is a terrible driver of dementia risk. Well, when your primary care doctor does not know that, they may not ask you, how do you sleep and how many hours of sleep do you get and are you tracking that? So once they begin to get this inculcated into their medical education, boy, then there are extra tools that they can utilize to bring to their patients' benefit. The other opportunity is this, through the American College of Lifestyle Medicine, they now have residency tracks, so medical school, residency training, attending level physician is kind of how that spectrum works. Well, they now have residency tracks where, primary care physicians in training can be taught to inculcate those things into their practice style. Because how you learn to practice is by and large how you are going to practice. And so you have to be able to bring them these tools, let them practice with them, see the utility of them, and then send them out into practice. And so that's the investment in how to do that.
From a larger health systems perspective too. So I think it's a little tricky, but so let's look at population health versus community health. So from a population health perspective, remember it's a lot of things like what can you do within your patient population. So there's always opportunities to be better in that space. So ICU. Catheter-related infections. So there's a lot of quality metrics that are already in place and thinking about how are you going to do better for the population who's in your ICU unit. From an ER perspective, I think that's a really good example. So what we don't want to do is put too many charges or tasks on top of our physicians who are trained to work in a very specific area. So I think there's a sweet spot between an ER doctor doing what they need to do, treating the acute reason for visit. But maybe there's an opportunity for like one extra thing. So maybe they are like really thinking, okay, why did this person come in? Okay, maybe it's an acute infection. All right, well that's maybe important then, like maybe we need a project to make sure that they're actually getting the follow-up that they need. So our project might be, are they going to can we check back in to make sure they got to their primary care? And that primary care then is really gonna try to address whatever they need to hopefully be healthier. Maybe they came in with some type of injury. So did there need to be a referral to address something in the home that may have resulted in that injury? So I think that there are different places. So it's probably about in those acute such situations, whether that's ICU or ER or even just like a hospital admission. It's why are they there and how can we maybe do that one extra step to help them not be back in this situation, which I really like that perspective. And then thinking about how we can impact the overall system to also think, how are we engaging the care team at the hospital? So Dr. Martin mentioned working to your level of license or working to your level of expertise. Social workers are amazing. So is there enough of a social worker presence in the ER who might be able to help with some of that follow-up? Are we engaging our other healthcare team? Do we have enough healthcare team support to make sure that we are able to provide comprehensive service to that person?
Okay, I think we have time for one more question. Well, so I'll close out with this question and ask, humans tend to be our own worst enemy. And you talked earlier about how we have to make sure that, so the healthcare providers will want to invest in our patients, right? But how do we convince the patients then to invest in themselves?
So, I opened up this lifestyle clinic 2 years ago, and the first year I wore my expert hat. As the doctor, I can tell you about diseases, I can tell you about the interventions that have been shown to be effective, and I really thought if I just showed you what your risks were, and I gave you kind of a map of, hey, do these things, now get out there and do something with that. Job, mission accomplished. And what I found was that probably about 40% of people could really engage with that and really move the ball on their health. And the second year in practice, we sent off one of our employees, my wife Elizabeth, to get a Willcoxon degree because they needed a coach. They didn't need me as an expert to tell them what to do with their lives. They needed to be able to have somebody help them figure out what would work for them. Now we know what our risk, and now we know the goal. How am I going to get there as an individual? I don't think that there is a cookie cutter approach that everybody in this room can take to get the same outcome that they want to. It has to be very individual, and so we need something between the person with the expert hat and somebody with the life that they want to improve, and be able to be like a coach on the sideline and help them get to the performance that they want to get to that result. And I really feel like that was a missing component that really amped up our ability to be successful for people.
I totally agree, and Dr. McNab mentioned social connection as being a really important piece of living. So for me, I think it's something achievable. Start small. I really think that starting small it's much better to do something small than nothing at all. And in a perfect world, yes, you have access to a wellness coach or a personal trainer or whomever else is providing that just a little bit of encouragement and just checking in with you, because it feels good when somebody cares. But for a lot of us, we may not have that space, and maybe then you find a friend. That friend is who can be your accountability person, who you can go on that journey with together, and who will also help your social connection. So,
well, let's give a round of applause for Dr. Satterwhite and Dr. McNab.
Thank you.